excited to have you all. Lisa Freeman has some updates for us.
Thanks so much. And thanks to Ame Alcantara, who's helping support this lecture series today. I have two announcements. One is that SMCI is seeking some volunteers to help with managing the logistics of projects and events that we put on, such as this lecture series. So if any of you are interested in volunteering, please let me know. And then I will put in the chat the link to the site where you can submit an abstract for the September 11th and 12th, 2024 9th Annual Lean Academic Healthcare Conference at Stanford. And we very much encourage all of you to put in abstracts for the conference. And with that, I'll turn it over to Sabrina to introduce our speaker. Thank you.
Thank you. So we have a wonderful presentation by Glenn Croft today, so I will introduce him. Friendly reminder, we will hold all questions until the very end of the presentation. So if you have any questions for Glenn, please provide them in the chat and we will facilitate a Q&A after. So Glenn Croft. He is an adult-gerontology clinical nurse specialist here within the nursing professional practice team at Stanford Medicine Healthcare. He specializes in plastic surgery, chronic pain management, and otolaryngology. In his role, he helps to oversee the translation of evidence into practice for nursing care as part of the professional practice team. Glenn began his nursing career in Austin, Texas, where he worked in a mixed bone marrow transplant and surgical oncology unit before deciding to continue his career in post-anesthesia care units in the Central Texas region. Prior to working here at Stanford, Glenn was a peri-operative clinical nurse specialist at Natividad Medical Center in Salinas, California. And with that, Glenn, you may start.
All righty. And a quick sound check. Everyone can hear me okay?
Yeah.
Wonderful. So good afternoon, everyone, and thank you so much for having me here. I briefly just want to thank the Stanford Medicine Center for Improvement, as well as Dr. Sabrina Orique for encouraging me to present at this lecture series. And then lastly, I just wanted to dedicate my presentation today to an evidence-based practice fellow. Her name is Geraldine Pritchard, who I've been coaching over the last year under the directorship of Dr. Barb Mayer and Dr. Mary Lau. She just graduated from her fellowship, and I'm just so proud of her. And so this presentation today will be about, it's titled Feasibility to Organizational Implementation, and it's surrounding heat and moisture exchangers for tracheostomized patients as a framework for highlighting feasibility to organizational implementation. And so to begin, just by a show of hands on video or via reaction, how many of you have had an idea to implement into practice, whether you have implemented that idea or it's just been a brainstormed idea to improve patient outcomes, to improve care by interdisciplinary members, to enhance care for our system? Anyone? I see Lisa's hand go up. I see quite a few hands go up. So thank you so much for that. And so I will ask everyone, again, very briefly, I want you to imagine having an idea. It could be an idea that you've previously had to implement into practice, whether on a small scale or perhaps an institutional level. And I want you to consider all the steps to achieve translating that idea from a pilot practice and subsequently scale it to an institution-wide practice. Does this sound daunting or intimidating? Who would you work with? What data would you need to drive this? Who could assist you with the data analysis? What steps would I take to achieve this, and in what sequence would I do so? How would I educate and socialize this change? So my intent is to provide some tips and tricks to do so kind of through the lens of a clinical nurse specialist on the professional practice team. I have no financial disclosure nor conflicts of interest related to the material from this presentation. This includes no commercial support nor sponsorships. And so Sabrina just gave that wonderful introduction to me, so I will not reread this slide. And on the right, this is my recent glamour shot taken last month. Do you all remember glamour shots in the 80s and 90s? And then I think they dissipated in the mid-90s. So I would like to just share what a clinical nurse specialist is with everyone. So we are masters or doctorally prepared advanced practice nurses, and our function is to improve outcomes in patient care. We are experts in clinical practice, we educate, we're leaders, we're researchers, consultants, and we really work on three spheres of practice. This is the patient sphere, the nursing sphere, as well as the system sphere. And with this, we work a lot on implementation science initiatives and taking what the research says and putting that into practice. For example, with some work, we will take the consensus of large compilations of data from the research sector of healthcare, such as nursing and healthcare-centric randomized controlled trials, quasi-experimental studies, meta-analyses, systematic reviews. I know there's a lot of jargon, but this is what we do. And we review these, we appraise these, we synthesize these, and we take these overarching findings from the studies, and then we can pilot new practice and kind of aim for large-scale implementation if the data in terms of our process and outcome metrics are successful. Okay, so what will we be discussing during this SMCI lecture? Again, this presentation includes some aspects of implementation science, but also the art of implementation. This includes communication, partnerships, professional practice, the art of educating and disseminating and socializing. I feel it's important, to put an emphasis on the above. This is one method. I say this because here at Stanford Healthcare, there are numerous means by which to take something from an idea and to implement it beyond the institution or to the institution or enterprise. Some of these examples include here at Stanford, we have CELT, we have WRITE, we have action request forms through evidence-based practice fellowships that can scale up, and through other facets. This certainly isn't exhaustive by any means. And I will kind of define CELT in the next slide here. So I know this is our Stanford Medicine Center for Improvement that is hosting this, and I'm kind of defining CELT, so I hope that I do a good job for you all. The Center for Improvement offers these team approaches to learning, improvement science, and complete a complex project with a multidisciplinary team. Some of these are right. This is realizing improvement through team empowerment, and CELT, or clinical effective leadership training. As said, the teams are interprofessional and interdisciplinary, and to my way of thinking, this really contributes to the likelihood of success of them. And during these team approaches, we have a clear problem statement. We explain the background that kind of aligns with organizational goals, and we set a SMART goal. We look at the current state, we analyze the contributions to the current problem, we identify key drivers or things that need to be in place for our process to be successful. And we then create interventions that are linked to these key drivers and establish a plan to then sustain the improvement. So the heat and moisture exchanger biomedical device was introduced as part of a CELT on Unit H1, which is our otolaryngology head and neck acuity adaptable unit. The CELT was coached by patient care manager Mary Beth Cambridge, and it was sponsored by Sharon Hampton and Dr. Edward Damrose. So thus, in essence, we had a group of interprofessional and interdisciplinary team members. We had tools and resources, as well as operational and clinical leaders to support this noted opportunity. And when beginning CELT, we didn't necessarily know the answers of how to approach the problem, but it gets everyone in the same room to address these lingering micro, meso, or macro system opportunities. So prior to beginning CELT, there were some noted high cost to patients as well as the organization when caring for tracheostomized patients. We knew the successes of HMEs or heat and moisture exchangers for total laryngectomy patients, and there was a re-emphasize on source control from secretions. This was really brought upon by the COVID pandemic. And there was research also speaking to the quality of HMEs, and thus the CELT group brainstormed, why don't we look at this novel HME for tracheostomized patients? And so the trach phone that we utilized here optimizes breathing and pulmonary health with additional features for suctioning, administering supplemental oxygen, and it allows for speech as well. So I think it's important to give some background about kind of anatomy and physiology to understand kind of what this is. So after a tracheostomy, a patient breathes directly through the tracheostomy in their neck. They bypass their upper airway, which is a natural humidification and filtration function, which is essentially lost when you have a tracheostomy. So your nasal concha aren't able to then warm and moisten the air that is going in. Historically, patients have used humidification via a trach mask. Some people know that as a trach collar, and the HME, like a trach mask, can provide similar functions. So when exhaling through an HME, the body's own warmth and humidity are retained by this hygroscopic foam that is impregnated into this HME. The humidity and warmth of the air is saved in this treated foam, and then it's subsequently released on inhalation when the patient breathes back in. And so the HME serves a very similar function to the traditional heated humidification or trach collar setup. So what was demonstrated during the CELT? So the CELT demonstrated that the use of a heat and moisture exchanger, again, as opposed to using a trach collar or trach mask, resulted in a significant cost reduction to patients and the organization. HMEs cost approximately $3.40 per day, while the traditional setup costs about $7.17 per day. Furthermore, outpatient costs are about $102 per month versus $307 per month with the traditional setup. What did patients say, and how did patients tolerate this? Well, 75% of the patients prefer the HME over the traditional humidification setup. All those who tolerated the HME were satisfied with the device as well. RNs loved it. They reported less clutter, perceived decreased fall risk, decreased durable medical equipment setup time, ease of mobility around patient care areas, decreased noise. Patients were sleeping better. And so I just ask you as a group, kind of by a show of thumbs up, how many of you have walked into a patient care room of a patient with a tracheostomy that have had a tracheostomy mask or trach collar, and it's been hanging off of the neck too low? It's on the floor, or on the bed, or not attached directly to the patient. Yeah, so several of you, right? And so these were some of the realized benefits and noted benefits. And so why were patients so satisfied as well? Like nurses, patients, LIPs, APPs were all satisfied with this. This gave them more comfort. They didn't have something around their neck. It gave them more autonomy and freedom. And it consistently delivered this warmed, moistened air, thus decreasing the tenacity of secretions. Because when you don't have that warm, moistened air, it creates tenacity, and your secretions are very thick secretions. And so this CELT was successful on a piloted unit, AAU-H1. So the question is this where we stop? And so, no, absolutely not. This is honestly where the work as a CNS begins as part of the professional practice team here at Stanford, and close alignment with our practice integration team and our implementation scientists. We again help to translate the research and successful piloted projects into large-scale practices across the organization. And this is done in consultation, of course, and in collaboration with many interdisciplinary professionals. And yeah, so this is especially true that we utilize CNSs here at Stanford Healthcare because we have so many numerous departments, specialties, levels of care, and disciplines. Okay, so socialization and cascading of this CELT success at forums. This is kind of the first step when taking it from a pilot to moving towards organization. It served again as an introduction to other members of the organization and highlights the quality improvement initiative and impact on care. It's so prudent and important to always leave or attempt to leave time for feedback, constructive feedback. The success of these heat and moisture exchangers were presented at CELT graduation, patient care services, clinical quality improvement outcomes meeting, professional practice, clinical improvement forum, patient care leadership meetings, and many others. And so the next step would be meeting with interdisciplinary and interprofessional stakeholders about feasibility. I connected with different disciplines and interprofessional stakeholders to ask if their department would essentially be willing to hear a presentation on a new device that has been shown to be successful during a CELT quality improvement project. So we meet and consult with members who specialize in practice. We always want to ensure that stakeholders are exhaustive or as exhaustive as we can be, leaning on others. So we lean and leverage the expertise of those who are experts with connecting people. For example, I met with Trish Britt, who was the director of professional practice at that time, for her wisdom and ability to connect me with relevant stakeholders. And at this time, when I've been started scaling this project, I had only been with Stanford for approximately 3 months. And so it was challenging, but I leaned on those on my team, my managers, directors. Always leaving time for questions, constructive feedback. As I said, it's so important to form strategic partnerships with those who ask questions and show engagements when highlighting this at the meeting. Begin asking for feedback and what they'd like to see if this was to move from a pilot and scaling it up. I think it's very appropriate to create timelines and expectations when requesting feedback as well. Me personally, I'll frequently compose emails saying something along the lines of, please kindly provide feedback by this date. And so I began by creating a clear, digestible, just trying to be as engaging as possible presentation highlighting the work of the CELT quality improvement initiative. And over the course of 5 months between June 2022 and November 2022, I brought this presentation to respiratory care practitioners' monthly meetings, to speech language pathology monthly meetings, to case management, social work, interventional platform, unit-based medical director, PCM dyad, which I think is also called all hands meeting. And several meetings trying to get the word out there, making sure that we're engaging everyone who would be a stakeholder. Okay, so meeting with interdisciplinary, interprofessional stakeholders continued. So we had to, for devices, we have to do supply and distribution planning. So with expansions of initiatives that relate to supplies or devices, it's of utmost importance that we include our supply and distribution colleagues so that we're not delaying the release of this initiative, right? We have to consider the financial aspects as well as strategizing the stocking locations and volumes based on usage. So these devices have to go to like a value-based committee, which has many interdisciplinary members who look at the financial aspects, volume requests, associated costs, cost comparisons, etc. We have to look at with supply and distribution, PAR allocation levels, anticipated usage rates, and determine procurement volume. But again, this is why we do it as a team approach. I cannot do this without these team members. And then additionally, for this, we had to do electronic health record ordering and updating. So this was an essential step to ensure that the EHR was updated to utilize this new device to document on it and to order it for providers. And then next is to consider feedback from stakeholders and then implement interventions based on the consensus. So heat and moisture exchangers were, as I said, shared at monthly speech-language pathology meetings. There were concerns about multiple devices that connect to tracheostomized patients, and there was agreement from our respiratory care practitioner department. And there was this opportunity to clarify the fact that we can attach passing-ear valves, trach caps, and HMEs. And there was this fear that there would be some confusion between these devices. And so after weigh-in from them, and I wouldn't have thought about this, nor did anyone in the CELT think that we needed to make maybe a head-of-bed alert for this, just to kind of cue our nurses in and providers into what this was and how it was different from those devices and who to call appropriately for those respective devices. And so EHR documentation and ordering optimization based on feedback. So we did have to create fields for RNs to document the presence of an HME. And this actually allows me as well to run reports on heat and moisture exchanger usage. Excuse me, take a quick drink. Okay. And then I worked with clinical systems analysts as well as our associate chief medical information officer to kind of augment the LIP-APP respiratory orders. And this allowed for seamless ordering of the HME by the provider. We shared the indications, contraindications based on the manufacturer's instructions for use and the type of patients that SHC leadership wanted to allow to utilize this. The next step was policy and procedure alignment with practice updates. So we had to update policies to be inclusive of this new device, and we would need to do so with other devices as well if they have implications in policies. And so with this, we updated the tracheostomy and laryngectomy care policy. So why is this important? It's important that policies reflect our practice and vice versa. It's also a resource to staff when questions arise relating to care surrounding the intervention device or new practice. This is for LIPs, APPs, nurses, those in laboratory, wherever you may be, we have policy tech. And so how do I begin this? We want to connect with content experts, those who own policies, and propose language updates to all the necessary stakeholders, and then subsequently have the proposed changes shared at our clinical approval committees, policy approval committees. And then this next slide here just shows, what we're looking at here is the clinical approval process for policies and procedural documents. It just helps to understand how complex it can be. However, like with that being said, we have individuals that can help us, get through these processes. We have, people that manage these policies and are experts in moving policies through the committees that help us through this work. And I had that with the tracheostomy and laryngectomy policy. Next, we talk about the creation of education and subsequent socialization. So those pictures on the right kind of highlight the education that we created for nurses. The one on the top and then the top kind of right is what we created for nurses. And then we created kind of a scaled down vision that really honed in just on the general considerations, the indications, contraindications, and EPIC components for our LIPs, APPs, as to not overwhelm, but just really hone in on the most important aspects. I have a quote here that education should be unambiguous, visual, and at a basic reading comprehension level. And this was actually something stated to me by a Joint Commission regulatory agent when they were visiting at a former hospital. And that just really resonated with me. And I realized how impactful that is when creating education. And I kind of used that as a framework for future education that I created. And then I'd just like to say, when creating education, it's so important to, collaborate with those who are experts in creating education. And we have the Center for CEPD, Center for Education and Professional Development, I believe, professional practice unit educators when speaking about nursing. And I think it's important to set deadlines for feedback if you're working on that. And then this is just kind of a larger view of what we made for the nurses. I just wanted to highlight how we, just made this very visual, good white space, and digestible, covering like all the features and other devices that there are. And so when we are socializing education, it's so important. This is such a crucial point to me, to perform upstream education prior to initiative going live. We want to ensure that education's disseminated throughout all impacted areas, right? And that we use forums that can further cascade they can further cascade information to the end users. With respect to it's disseminated through all impacted areas, for example, with this, we took the HME to weekly professional practice, UBMD, PCM dyad, APP shared leadership, unit educator forum, and several others. And then bullet 4, it says utilize multimodal multimodal education. Again, this is crucial. We know that about 70 to 80% of adults are multimodal learners. And so it's important that we utilize presentations, emails, in-person rounding, allow them to have kinesthetic touch of these devices. And so I would go around and bring the HME to units that wanted to learn more about them. Okay, and so this is actually towards the end here. So the practice is now organization-wide. And so what is next? So sustainability. So I monitor with informaticists the HME usage here at Stanford Healthcare. We currently haven't had any sentinel events or troubles with negative outcomes, knock on wood, and I will ask that all of you knock on wood for me as well. And then scalability beyond the institution. So we are in current discussions with Lucille Packard as well as Tri-Valley to look to see if this can scale beyond just Stanford Healthcare for adults here in 300 and 500p. And then also publish. So I always think like, what can we do next? What can we do next if we see that this is, beneficial for patients? And so a group of about 9 of us worked together and we published in the Journal of Otolaryngology Head and Neck Surgery this quality improvement project. And so I'd lastly like to say 2 things, both of, I suppose, maybe moral and intellectual content. First, I would like to say that this work, scaling from an idea from infancy to an organization practice, it's not without challenges. In fact, I have trouble believing anyone that states, translation of an idea to implementation, whether a pilot or small scale to macro based, is without challenges. Challenges and hurdles are going to challenges and hurdles to me are about going back to the drawing board and are a normal part of implementation and scalability and transferability. I really just want to normalize that thought and that point. I think what's crucial is that we don't become stagnant and we just continue to brainstorm methods to kind of push forward. I know that there's no I in team, and that's quite the platitude, but kind of to me, it's a valuable reminder. Lastly, implementation projects may not look exactly how a team had anticipated or imagined it in the first place. In fact, I think there are times when compromise may be necessary, but it's you and the team who has to really understand the subtleties, nuances, granularities of how implementation may impact patient care and those involved, and determine when it's okay to compromise and when you have to take a firm stance. There's actually this song by the Rolling Stones. Many of you may know it. It's like, you can't always get what you want, right? And the lyrics go, you can't always get what you want, but if you try sometimes, you might find that you get what you need. And I feel that idealism often ends in frustration, and we can't we can prevent this by kind of understanding that implementation will look differently than originally brainstormed or imagined. So become comfortable with the idea. Becoming comfortable with the idea can help be more realistic. And sometimes getting what you need is sufficient to achieve a goal and improving patient care. I suppose now all of you know that my karaoke go-to song if the Stanford Medicine Center for Improvement decides to host a karaoke night. And that is the end of my presentation. So I just want to thank you all very much.
Thank you, Glenn, so much for your presentation. We have time for any questions. And so if you have any questions, please provide them in the chat and we will facilitate them. And please don't forget to record your attendance so that you can claim your CME. So Glenn, I have a question for you. In you discussing the whole process from implementation, if you were to do one thing different within the group, what would that be? Because a lot, like you said, within nursing, a lot of us, it's not a one-person team, right? Is a multidisciplinary approach. We're collaboratively always working and executing changes in practice, but with approval from many different stakeholders.
Yeah, absolutely.
Something from this that you would do differently?
Yeah, and I think accountability is a huge aspect. And, I have made missteps during this. We are human, we make mistakes. And so with this, I think that we reached out and worked with supply chain a little bit later than we should have. We should have brought them in earlier because it brought up some challenges when this was going house-wide in terms of having it ready for the PAR. And if we had kind of reached out to them maybe 3 to 6 months earlier, that really could have helped facilitate making that a more seamless process. And that was a lesson learned from last time, which I will certainly integrate into my practice during, the next project, if I'm to take something and scale it up surrounding a device or something where supply chain needs to be included.
Charlene has a question. It says, you may have addressed it earlier, but did you know any changes in patient satisfaction when the new device was implemented?
Yes, so the patient satisfaction, I can only speak to the surveys that we sent out in Qualtrics with the heat and moisture exchangers. But we asked questions about traditional humidification versus heat and moisture exchangers. And some of the noted points of satisfaction were the decreased noise. Patients said that they were able to sleep better. Patients also stated that they didn't feel tied down because trach collars are around the neck, right? And you have to carry the humidifier with you. And so these were noted things by the patients that just made us so happy, because right after you get a tracheostomy, you don't want to just lay in the bed and sit there. This helps get them up. And I don't know, to me, this novel technology is just such a game changer for patients. And then, since we have implemented it, we continue to use it throughout the organization in H1, and patients, again, they love it. Are there contraindications, though, to it where certain patients have to use trach collars? Absolutely, there are. If patients have thick secretions or tenacious secretions, they cannot use it. And so they don't get the chance to be satisfied by an HME.
Great. And another question is, can you talk about how you collaborated with others outside of the organization or learn from the best practices that others have implemented?
Yeah, that's an excellent question. So during this implementation process, I really didn't find any organizations. I actually did some emailing and some calling, talking to fellow academic institutions about heat and moisture exchangers for tracheostomized patients. I could find other organizations that were doing it for total laryngectomized or total laryngectomy patients, but not tracheostomized patients. So I wasn't able really to collaborate outside of the organization in terms of that. However, I did work very closely with the company that sells and manufactures these heat and moisture exchangers, and they helped us tremendously. They're educators and education specialists. In addition to that, again, most of the collaboration was in-house, and now we've started discussions with Lucille Packard and Tri-Valley.
Thanks, Glenn. This is Trish. I just want to call out, I just really appreciate all the thorough work that you've done, and then also being able to publish on the work, going to the evidence, adapting it to the context of the patient populations. And just thank you for highlighting all the strong interprofessional collaborations that you've had here at Stanford, but also the diligence of reaching out and trying to really understand what's out there. Thank you.
Yes, ma'am. Thank you.
And there's another question. This is from Sierra Kane, kind of based on the you don't know what you don't know conundrum. But when you came here at the time that you were working on this, you were fairly new. So can you speak to about what advice you would give to folks who are new to the organization and trying to navigate what stakeholders to involve?
Yeah, I think that's an excellent question, and people may answer this differently. But I think like our team, the professional practice, is a great team to leverage to look at stakeholders to improve, to move something from feasibility to organizational implementation, and then seek those who have been with the organization for significant periods of time. Those whose standout strengths, like Trish Britt for me, is a connector and knows different stakeholders and knows who you need to connect with to help make these yeah, to help make these types of projects successful. And so those are just a few tips I would give. So what I did when I came to the organization is, I spent a lot of time with my managers, directors, director, I should say, learning about the different departments. And then also just when I would collaborate with other interdisciplinary members, such as respiratory care practitioners or speech language pathology, they would then give me ideas of others who I needed to connect with. So connecting with those experts in those respective departments can give you this kind of unique lens of others that you might need to involve. And so those would be some of the tips and tricks I would give someone who's new to the organization.
Great, thank you. If there's any other questions at this time, please put them in the chat and we can follow up. But thank you. It looks like that's all the questions right now.
I'm just going to make a comment, Sabrina, for Glenn, because it sounds like this is very much a part of how you were successful. We had a presenter one time, and you have that nice kind of flow chart of how you socialize the intervention across all these things, and we had a presenter talking about a project in cancer treatment of children at Lucille Packard, and she did the same thing, but instead of like processes, it was all the people. So like, all the people, starting with herself and maybe her first collaborator, which was a physician, and then like drew these branches off in all these different directions. I don't know if you've ever thought about doing that, but it might be something that just as a visual would be helpful to others to just, because it very clearly illustrates the complexity of implementing a change or even socializing the possibility of a change such as this in our ultra complex healthcare environment.
Yeah, you bring up such a great point. And I think that maybe a blueprint or a framework like that could be constructed. But I also, by the same token, know that there can be like nuances, right, to projects where it might veer off one direction that you might not have anticipated, right? But I certainly think that maybe like a blueprint, something simplistic with like, these are general instructions for maybe how to disseminate and socialize through forums, but it might not be like all encompassing or something along those lines. But I think that that's just a beautiful idea.
And I hope everybody saw in the chat that Trish offered herself as a connector, and she's an amazing connector. So I hope you all took note of that and take her up on that. Thank you, Trish.
Anytime.
Thank you, everybody, for your time. And please claim your CME.